my name's Haniya.
I'm Natalia.
And I'm Stephanie.
And we're going to be going over the IPV, also known as the intropulmonary percussive ventilation. I'll be going over the introduction and some indications.
I'll be going over the contraindications and how to set up the device.
And lastly, I'll go over the initial settings and give you guys a little demo at the end.
So the IPV is a pneumatically powered device that delivers air and aerosol in high-frequency pulses to help move mucus and aid in lung recruitment. It is a pressure-limited, time-cycled, high-frequency mode of ventilation that delivers tidal volumes. So it sends the fast, small burst of air that loosens and gets around the mucus to free it from the trapped airway walls. The continuous aerosol helps the mucus become less viscous or less sticky. So the IPV doesn't actually cure any disease, but rather help in secretion retention or to treat atelectasis. So for example here, if Ron had cystic fibrosis, this machine would be great in helping him. The IPV would be used in providing an alternative delivery system for bronchodilator therapy, providing intrathoracic pressure and vibration, and providing an alternative system for delivery of positive pressure to the lungs. Other indications would include bronchitis, bronchiectasis, bronchopneumonia, neuromuscular disorders which produce pulmonary symptoms, restrictive lung disease with recurrent atelectasis, post-thoracic and abdominal surgery, patients with artificial airways who are unable to maintain those clear lungs, and to prevent the development of disease caused by secretion retention. So lastly, an IPV is used in acute care settings to critical care settings. The IPV intervention is used in a wide range of patients, from spontaneously breathing patients to those receiving invasive mechanical ventilation, where IPV breaths can be imposed on the patient's breathing cycle.
So the absolute contraindication for IPV is untreated tension pneumothorax. Relative contraindications would be intracranial pressure, tracheoesophageal fistula, hemodynamic instability, active hemoptysis, recent postoperative esophageal, facial, oral, or cranial surgery, active and untreated tuberculosis, and patients should not receive this treatment immediately after eating because of potential gastric insufflation. I'll be setting up the IPV. This device requires a connection to a 50 psi outlet because the patient will be receiving 100% FiO2 during the treatment. I'm going to plug this into the quick connect here, and then this is how you'll set up the device. So you'll assemble your phasotron. The phasotron has a nebulizer cup on the bottom where you can add your normal saline or prescribed medication. On the top is where you can attach either a mask, mouth guard, or invasively in line with a ventilator circuit during continuous mechanical ventilation. Today we have it attached to a mouthpiece. This device has a pressurized line that's color-coded. The red is for the gauge. The white is for the phasotron, which is the pulsation piston that allows treatment. And the yellow is for aerosol. So you'll just do the red to red, white to white, and then the yellow to yellow. And then on the opposite side, you'll attach it to your phasotron. On the bottom of the nebulizer cup is where you'll see the yellow, the white to white, and then the red will go in the last slot.
So I'm going to go over the initial settings on the device. It uses a pneumatic device to deliver a rapid series of pressurized gas minibars at a rate of 200 to 300 cycles per minute to the airway. The patient can still inhale and exhale through the device as the oscillating airway pressure is applied. It actually has 4 operator controls. So the gas enters at a 50 psi and it's directed through a pressure regulator. The on and off switch here, so when it's on, it will open up. If it's off, it will prevent the flow of gas from the compressed gas source into the pressure regulator. The operational pressure here, this makes adjustments to the device's working pressure. The front panel contains a aneroid gauge. This displays operational pressure gauge, and you want the driving pressure of 30 to 40 psi during IPV to achieve therapeutic effects. And the percussion control here, This determines the number of flow bursts that occur during the breathing cycle. The percussion frequency is adjustable from 1 to 11 hertz. And when the airway is increased, the pressure amplitude decreases, and as the frequency decreases, the pressure amplitude increases. And lastly here, there's a manual inspiration trigger. This device will remain in the inspiratory phase as long as this button is depressed. By releasing the button, it'll allow passive exhalation. Alright, so I'm going to give you guys a little demonstration. You want the patient to be in a semi-Fowler position. You want to instruct the patient to have a secure seal over the mouthpiece and breathe normally through the treatment. If the patient cannot maintain a tight mouth seal around the mouthpiece, they may use a mask. And also, you want to allow the patient to take a break so they can cough to help clear secretions and suction. So let's turn on the device. We're going to turn the knob from off to on here. And then from here, we're going to adjust the operational pressure. So you want the aneroid gauge here to be between 30 and 40 psi. So I'm going to turn the knob to the right. And as you can see, the gauge here is flickering, and you want to keep turning it until it's between 30 and 40 psi. Okay? You want to adjust the percussion control. So as the frequency is increased, the pressure amplitude decreases. As you can hear, it's increasing. And then as the frequency decreases, the pressure amplitude will increase. And there you go.